Guillermo, you on?
Thank you very much. Well, good afternoon and good morning, depending on your time zone. It's a pleasure for me to introduce you to our organized session. The name of our organized session is What's It to Plan Today for More Equitable Tomorrow. Excuse me, should I share my screen with you? Give me a second. Okay. So our moderator will be Jean-Paul Dussault, and then several presentations will be done by some of the alumni of the Emerging Bases for Global Health. And I'm going to have the pleasure to introduce you to the master presentation called Applying a System Perspective to the Health Policy Cycle to Address Inequity in a Complex World, from Potential to Practice in Low and Middle Income Countries. Well, the idea to begin with this presentation will be to give a frame for the discussion that we are going to have afterwards in the session. So it's important to notice that today there are still important health inequities, as such that you can see some of them in these slides. For example, that in every day 16,000 children die before age 5, in 14 times more likely in sub-Saharan Africa than in the rest of the world. Or another important fact that are as well brought by the WHO is that in poor countries accounts for 99% of the annual maternal deaths that happens in all the world. So it's important to see that COVID has brought and make it more present those health inequities that we lived in today's world. And this is a graphic showed by the Harvard University coming from United States, showing that Black, Indigenous, and Pacific Islanders and Latin American people are dying in many times more than people white out from Asia. And this is very striking because there's no reason for this situation. And in many times, the groups of population are smaller than the amount of the people, specifically for the people from the white people in United States. So it has been like very much discussed, and there's an additional coming amount of evidence showing the type of health inequities that can arise about this kind of disease and diseases. So what are health inequities? It is important to identify that health inequities have been long with us already, and it has been an important discussion in the last years. For example, in 1990, Margaret Whitehead described health inequities as a difference which are unnecessary and avoidable, but in addition are also considered as unfair and unjust. And she added, not too many years ago, in 2007, that this type of differences can be systematic and socially produced. This is important to acknowledge because that starts to give us a frame of how this problem, it's a very complex problem, and at the same time, it's possible to address it because it is man-made. So to explain better and maintain health inequities, there are several considerations that have been shown by Source and Carpentier in the last year in a concept note that was presented by Enable and the ITM. And it shows, for example, that the process is part and parcel of inequity. So that means that understanding the context and the capabilities of the population and the interaction that it has with other many aspects and topics is very relevant. You cannot address health inequities just by talking about a specific aspect of these inequities. You will need to address many other topics that are around it. And another important aspect is the dynamics of power that happens around health inequities and how this kind of privileges and other aspects that can like show this type of power dynamics have an important role in how the health inequities developed in a place or in a country. So inequities can be undone as they are made by men as well. So inequities are essentially about people. It concentrates and are generated by people as well. So we will need to account for the type of leverage for change that are actually on the places we are talking about and discussing about health inequities. And those inequities are systematic and systemic. That means that we will need to untangle or to try to understand what are the structures that causes these inequalities and how these are interrelated between one and the other. And finally, the last consideration that was mentioned was that consensus on what fairness entails is needed. That means that it is very important to understand what an unfair situation means for the population or for the stakeholders, actors that are in relation with these health inequities, to see at what extent they believe these situations are unfair or not, to be able to address these topics. So a few years ago as well, Thomas Piketty came out with this equation about showing how the rate of return of capital tends to exceed the economist's growth rate. That means that in the long tends to lead high concentrations of wealth, and this relation is related to the amount of people that have more wealth and income that tends to increase, and the amount of people that have less tends to have less in the future. So more than 50% of resources are now in the hands of these top 10 richer people in the world. So this example is very useful to help us to frame our session and our hypothesis. That is that there are underlying and sometimes long-running forces that explain unequal distribution of health, and at the same time, effective policymaking processes that explicit and address those forces may change the game slowly but surely globally in local and in low and middle income countries. So to address this conversation and our session, we're going to use the Iceberg systemic thinking tool or guide to try to untangle and to explain these different forces that we have identified and health inequities in specific cases that our moderator will introduce to you. So I will finish for now with this slide and give the microphone to our moderator to to explain the dynamic that our cases is going to have. Thank you very much.
Thank you very much. Thank you very much, Guillermo, for this very brilliant introduction. So on the slide of the iceberg, the idea, as you said, is really how do we try to go back deeper in the structures and in the mental models that explain what is seen as unequal distribution of health outside, and that is visible. So this iceberg model is a tool that guides systemic thinking, and that conceptualizes a problem as a kind of iceberg with a visible part. And underground, we have 3 layers of this problem that are not visible. So the visible part are the events, and it's defined here as what just happened. Most of the time, it is what we tend to react to. But underlying what just happened, we have trends and patterns, things that tend to happen in the same configurations or in the same kind of situations of similar things that are happening for other groups of population. So what trend has been there over time, but it also relates to what tend to happen in similar contexts or situations. And what is underlying that are the underlying structures. Indeed, they are kind of constraints, norms, structures, and relationships that create systems that sustain patterns and trends. But under those structures, we have assumptions, beliefs, values, what people think are right or wrong, are just or are fair or unfair, that make them sustain the structures. So we strongly believe that this iceberg model can help us to go back to those, to try to make explicit those underlying forces that can be there for times, for very long, that are explaining what we are just seeing now as huge gaps between in the distribution of health when we use various parameters across the globe, or even in a given country, you can have huge variations between various groups of people, even in rich countries or in poor countries. So on the next slide, what you will see is that we are introducing you here. We are going to present you 2 cases. So the first case is a case that is titled Embracing Complexity in Thinking and Working About Health Inequity in a Politically Inequitable System. So this is a case based on South Africa experiences, and it will be presented by Ferdinand, and it will be followed by another case. So the second case will be grounded on communities and the role of communities in, for instance, the response to COVID-19 in India. And this will be presented by Shinaz. And what will happen after that is that we will have one emerging voice who will really challenge the basic assumptions and the claims that will be made by those who will present those 2 situations. And based on that, we will see what we can learn as a group on how, using this system thinking tool, we can really move away from sometimes reactive ways to address situation to focus more on deconstructing the structures, identifying underlying forces and addressing them in a more sustainable, to have changes that can sustain for more long periods. So on that note, I will ask Ferdinand if he is ready to share his screen and present us the case from South Africa. Ferdinand, the floor
Yes,
is yours.
yes, and Jean-Paul, yes, I'm ready. I hope I have the rights to share. Yeah.
Yes.
I want to welcome all of you to this session, and thank you for joining, and I hope you're having a wonderful day. I'm going to be presenting the first case study, as Jean-Paul has indicated, and we're going to be looking at, we're going to be, in this case study, I would try to embrace complexity thinking, and especially in an inequitable political system. And I'm going to be looking in particular within this case study in South Africa. I want to look at migrant inequity in South Africa. So first and foremost, before I move forward in my presentation, I want now to adopt the framework that is guiding our systems thinking. And I'm going to indicate how in this presentation, I'm going to use this framework to inform or to be able to conceptualize the issues that asylum seekers, refugees, and foreign migrants are encountering in South Africa regarding health inequity. So we talked about the first one being events, and then we'll look at the experiences of the migrants, and then patterns, and that patterns I'm going to be using the WHO framework of analyzing the vulnerabilities of foreign migrants. And then underlying structures, we're going to see through this presentation that the underlying structures that could be identified are nationalism, xenophobia, and political opportunism. And the models, or what keeps the system in place, is the culture of inequality and inequity in South Africa, which are the relics of the apartheid systems. So I'm going to use the WHO's framework to be able to share the experiences of migrants and to expose the inequity and inequality that this population is facing in South Africa. So first, we're going to see that regarding nationalism, in the recent times, there are more of the laws of regarding refugees in South Africa. They are changing, and there are now cries that these changes are now undermining the human rights of refugees in South Africa. So we also know that South Africa is one of those countries, especially in Africa, that has an endemic xenophobia that really discriminates against any foreign national, and mostly foreign nationals from the African continent. So that is why you would see South Africa has a very widespread xenophobia, and it has the violent type of xenophobia. And the reason for this xenophobia is usually blamed that foreigners, they come and take the jobs, opportunities, especially from the African continent. They take the opportunities, basic services, and they are spreading disease and running crime syndicates in South Africa. And based on this now, that is why there is this xenophobic sentiment towards them. Also, we also have curtailed access to anything, to most of the services in South Africa. And this curtailed access is usually related to lack of documentation. And so you would notice that there is the Home Affairs system does not really support these people, especially the ones working on the immigration of people. And there is widespread corruption around this. So most other organizations have to step in, like churches, to be able to accommodate these people within the country. Health crisis. Regarding the health crisis of asylum seekers and refugees and other migrants, we notice that because of the poor documentation system, these people cannot work and they cannot fend for themselves, and especially cannot be able to afford accommodation. And so they are accommodated in just areas that they can find that they can just congregate together, such as what you find in the picture. And those environments do not make for very good living systems. And then there is also, because of all these problems that they are facing, refugees are willing or even asking the South African government to make to put in place systems for them to leave the country. Regarding the access to health, yes, the National Health Act of South Africa suggests that every person living within the South African border has rights to at least basic health services, at least at the primary healthcare level. Nevertheless, the Immigrant Act, still within the South African still within the South African government, also states that, but for somebody to be able to access these health services, they have to present themselves with a legal documentation. And we know that most of these asylum seekers do not really have this documentation, because the Home Affairs system is broken, like we've seen. And so we now see how the different systems are interlinked. The protection system that has to do with the documentation, lack of documentation, and then you cannot have access. So there is a whole systems thinking that has to be put in place for one to understand the plight and the inequity that this population is facing. And you would see people will say, don't send your sick here to be treated. Our own people need it more. So we also realize that food insecurity is a huge issue in South Africa, especially amongst asylum seekers and refugees. And this has been highlighted by so many authors within the country, showing that South Africa is not really taking care of this group of people, or they are not really considered within the system, whether it is the political, the economic, or the health system. These people are not really considered in any way, shape, or form. Socioeconomically, we also notice that most foreigners are facing a lot of barriers to economic empowerment. We also notice that there are also challenges. Being a refugee, you need documentation to get a job. You need also to compete now for this job with the nationals, and usually, obviously, you would always come second, except there are jobs that they are not really, that South Africans do not really care about. So there is enhanced protection and protection crisis during the COVID-19 period. The plight of foreign nationals really became clear during the COVID-19 pandemic, where even during the lockdown, where the Home Affairs were not open, they were still being penalized for not having valid documentation. During the COVID-19 period, while the government was sharing food, migrants were left behind because an ID documentation was required to collect food parcels. And these migrants would often say, we were denied food parcels because we are not South Africans, claim a foreigner. So these were some of the challenges which COVID-19 really highlighted. Even foreigners who were employed legally could not have access to their unemployment funds because they are foreign nationals. And even when the shops were asked to remain open, the Minister of Health asked that foreign shop should be closed and only South African shops should be open during that period of time. And we also see how the health crisis, even those who were in a refugee camp, the situation there is deplorable. This is during the COVID-19 period. There is no social distancing, no masks, no resources for them to be able to protect themselves as refugees. So that is the situation of foreign nationals in South Africa, and how systems thinking, looking at the different systems, the political system, the economic system, how they impact on the health systems of these people. So I argue in my presentation that a systems thinking would allow us to understand better the inequity of foreign migrants in South Africa. Thank you for listening.
Thank you very much, Ferdinand. This was a very clear presentation. And I will now move to Shinaz, who will guide us a little bit to India, and using the same way of thinking, She will try to interrogate how the response to COVID-19 have contributed to inequity or not in India based on COVID-19 example. Shenaz, the floor is yours. So you can unmute yourself, share your screen, and make your presentation.
Hi, can you hear me?
Yes, we can hear you.
All right, I'm just sharing my screen right now.
Yes.
Sorry, I'm having a little bit of trouble. Can you see my screen?
Yes, we can see your screen.
I'm just afraid I got the wrong. No, I've got the right one. Okay. So, welcome everybody. Thank you for this opportunity. As I am going to be presenting a little bit of thinking about the role of communities in health system governance, and a kind of an approach to advancing health equity. And I'm really looking from an outside perspective, and there's kind of a spotlight on community engagement and some of the differential treatment that different communities in India received during COVID-19. So bear with me as an outsider, but also let's broaden our mind as to who community is and how community navigates. So to start, we were looking at in India. So the first cases were detected in January, and some screening measures were put in.
Sorry,
but then around.
Sorry to stop you. The noise, your voice is not very clear. Maybe you want to fix a little bit the speaker.
Is it clear enough?
Yes, go ahead and let's see.
Okay, all right. So as I said, so we first had a detected case in January, which resulted in some screening processes in place. But then later on in March, the government announced a complete lockdown in 82 districts and in 22 states and the union territories of India. 80 cities were then under lockdown, and there was a lot of interstate border closures that really had an impact on people, their ability to navigate their lives. Transport was stopped, and there was a lot of preventative strategies put in place. We also had the COVID-19 Economic Response Task Force, travel restrictions, and kind of government committees that were formed. But in those committees, you can see an absence of community. So just a look around July 2020, we have one image on shows the India showing the confirmed cases of COVID, and you see that certain states were much more affected than others. And on the other side, we see some of the death and recovery rates. And you see again, cases, certain parts of the country were more affected than others. So when thinking about complexity, we've got this iceberg model where we really, which I think Sean went through, where you look at the events, just not just looking at what we see above the surface, but to really start deepening, to go down underlying structures and mental models. And to make sense of these, I've driven a little bit on two theories. One is the intersectionality wheel diagram, which starts to look at a person in the middle of the circle, where they really have life experiences that shape their life. And in the outer circle, you start looking at the certain characteristics, where they're born, their sex, their age, education level. Start going out, we can start looking at organizational levels. And towards the outer circle, we start seeing some of the broader elements of that shape society, that are structural, that include systems of oppression, such as ableism, racism, discrimination, heterosexism, class, ethnocentrism, ageism. And these play a role in how we think about complex problems. Then we've got intersectionality, the social determinants of health model. But I'm looking not at the one that most of us are familiar with. I'm looking at a revised model that came from the Latin American case study when the commissioners of the Pan-American Commission on Social Determinants of Health started to acknowledge under the structural drivers that we need to look at history and the legacy of ongoing colonialism, coloniality, structural racism. We need to look at the natural and built environment and climate change and other issues that really underline the deep and deepen our complexity analysis. So to go into the Indian case, there's a lovely website called On the Wire that really has a timeline. Ultimately, on the 25th of March, we had this national, I think 25th or 22nd, I'm not sure when it was, but a lockdown imposed. And the Prime Minister was tweeting that there's absolutely no need to panic. But he didn't really mention how are people going to get their supplies? How are migrant workers going to work? Where are people going to go? How are they going to cope in their day-to-day reality? And this is a large country with a lot of people, and it's regarded as the largest lockdown. Okay, what does this mean for poor and marginal people, and how do we make sense of differential experiences? And I just want to show you the death. So we have the deaths due to COVID, which is the infection rate. And you see the black line, it's rising from March right till May, rising quite high. Then at the bottom, you see another layer of rising deaths. And when you look at this, it's deaths due to hunger, deaths of migrants, deaths due to police brutality, access to medical facilities, suicide, stigma, lots of suicide, 3 different categories of suicide. One piece of separation from partners. Remember, many of the males in the family died in India. So men were much more affected, resulting in many women who were widows. Sexual assault due to provider of critical services, stress, and other reasons. So it's not just the shock and the death due to COVID, but you also have the human toll due to the extended lockdown and a lot of other reasons. And I think I've brought this image because this is the image that will sit with Indians for the rest of for the rest of history. It's a kind of human tragedy of movement of people who are on the fringe, the internal and the interstate migrants who were extremely affected by this draconian lockdown law that closed borders, closed transport, and just affected people's ability to wake up in the morning and go to their job, earn money, and put food on the table, and then to also pay rent. So what this meant is that Indians were forced to leave their accommodation, and many of these interstate migrants had to then go home, go back to their rural villages. And Mina was saying that a lot of the movement was from the south of India to the north of India. And then when the lockdown ended, people needed to move back. So you really have this human tragedy, and you can see from the images, people walked with their goods and people collapsed, many people died. And it really highlighted pre-existing inequalities. It showed how these inequalities and inequities were exacerbated. And in this case, when thousands are moving, social distance is really so here's the economic impact. We have an employment impact. Before lockdown, high employment rate, but immediately you have jobs shut down, small and medium enterprises shut down, interstate migrants, unemployed people. It's largely affected, and we talk about it as the second plague. Apparently, the unemployment rate has sort of leveled now, but this is the immediate impact. And if we start thinking of community and the impact of community, who gets involved, who gets to say, it's really people are responding based on a crisis and multiple crises. And then there's obviously differential consequences in terms of hunger, because you can't work, you can't feed your family, the maternal child deaths rose, domestic violence rose. Sorry, I've got violence twice, and hunger and nutrition twice, but this shows how bad the problem was. And then public shaming for people who didn't adhere to the rules, and agriculture as a sector. Farmers were affected, and in some cases, a lot of police brutality again. So if we start looking at some of the marginalized groups, we see that, women lost their jobs first. So it's not just that employment was affected, that the jobs of people were lost, that women were the most affected. And you look at how seeking behavior of women as well, it really affected them, because not only were their responsibilities much larger, if they were sick, it was difficult for them to actually go to the clinics or hospitals. And then you have women in rural areas worse affected, and a large psychosocial toll on women, especially the large number of widows that emerged. And then it gets worse when you start thinking of lower caste Indians, the experiences of domestic violence, the lack of visibility of women, and the religious minorities. And then education was another issue that was a real impact on communities and on people. What do you do when there's a huge digital divide? So people, some people could just log in and carry on with their studies, but a lot of people couldn't. And we saw young people in India, the high suicide rate, and the long-term impact of young children not having food, so the hunger and the educational consequences. What is going to happen to human capital in the future? What is that going to happen to employment further down? So students were really caught up in this worst situation, socially isolated, they couldn't play, they couldn't connect, and some of them couldn't write exams. So how were they able to go to college? How were they able to get their first job? There's a lot of students that really, across the middle income countries, but India was largely affected. And again, you have all these pre-existing inequalities in education between the private and the public schools. And again, the interrelated complex issues of hunger. So you have a school program and you've got Mitan health programs that were all coordinated together to really help those poor young children who were hungry in school with the lockdown regulations. None of those things were taken into consideration. I just need to quickly put my plug my computer in. All right. Thank you. I'm almost done. So then we have nutrition was also affected, and there's no support countrywide. Instead, each state had to. So some states provided nutritional support, some states provided some income support, some states provided no support. And overall, there was a kind of a fiscal stimulus to try to bring money into the hands of people. But again, those who were on the margins, those who were disabled, they were affected worse and had high rates of hunger. And we really need to think about the relationship between nutrition and health, and how, again, as I mentioned earlier with women, the poor treatment-seeking behavior as a result of sometimes not just home situations, social situations, but also shutting down some of the hospitals, the fear of contracting COVID, and inaccessibility of the private sector. And again, the interlaying of chronic diseases, how do you take your medication if you're hungry? What do you do? There's so many nutritional income inequalities, and what about children? So again, the hospital, India already started off with a multi-tiered and fragmented health system that really doesn't favor the poor. And within that very multi-layered fragmented system, there's a large level of mistrust that is present prior to COVID. And this is now exacerbated post-COVID or in the COVID situation. So when we start trying to apply this iceberg to really get to some of these underlying structures, how do we start making sense of what happened, some of the consequences and the trends and the pre-COVID challenges that showed up and were exacerbated post-COVID or during the COVID pandemic? What are some of these things? What are the values? What are the relationships? What are the things, mental models that emerge from there? And we see here, it's extremely complex in India, and it's difficult to fully, point out the reason, but some of the complexity theories allow us to think of a few things that may emerge that we can start grappling with, and that Mina will provide some following questions or really provoke us to think about. So we see here that farmers were protesting, saying that we are not terrorists. We had people who were shamed publicly in the streets and saying, "I'm not an enemy of society." What does this mean? There's stigma and a kind of a rise of nationalism, where certain people, groups of communities like Indian Muslims, face renewed stigma amid COVID-19 and were actually blamed in some cases for causing COVID or spreading COVID and so forth. And so what we do when we think about the value of life, when we think about trust, when we think about community-driven approaches, the culture of privilege, what happens when we fail to make explicit some of these mental models that underlie the things that occur, the ill preparedness for a global pandemic, which I'm not so sure that we could say we shouldn't have been prepared for. And what happens when our responses influence or impact mostly on those who are already previously disadvantaged. I'm going to stop there. Thank you so much.
Thank you so much, Shinaz, for this very good presentation. You really present several facts and at the same time try to raise several questions as an outsider of the India system. I think you did very great to really ask questions and eventually force us to think differently and try to move away from what we see outside to go more in depth and try to ask some key questions. And this is the right moment for me to introduce Mina Turaj. She's role in this session is really to challenge all what you have said. Ferdinand, Shinaz, you are quite relatively very confident in your approach, in your model, and you think that this is going to change anything in the situation. But Mina, are you sure that, are you convinced by their argument and the way they are analyzing those situations? And do you think that they are really bringing anything new in the discussion? Mina, the floor is yours.
Thank you, Paul, for this opportunity. Before presentation, I would like to share the screen. Give me a second. Hello.
So we can see your screen.
Paul?
Yes, we can see your screen.
Hear me?
Yes,
great.
we can hear you and see your screen.
Great. Okay. Thank you for this opportunity, Paul. So the presenters who spoke before me was very much convinced that the complexity sensitive approaches such as the systemic thinking tool or the Iceberg model or the intersectionality approach, all these are wonderful way of understanding the wicked problems of society. But however, I'm not convinced that much. I have several approaches and I don't see it. Firstly, I want to ask the complexity theorists, the researchers, whether they're actually able to capture the full picture of wicked problems because of the following reasons. So in interaction between the systems and all that, But given the limited time you have for your research projects, given the limited budget you have for your research projects, and being an outsider to the policy community most of the time, do you have full access to the data in first place to understand the wicked problems? Have a pressure in the academic world, there is a pressure to publish, otherwise you will perish in the field. So with all these limitations, I wonder whether the researchers, the complexity theorists are able to capture the full picture of the wicked problems. They are not able to capture the multiple dimensions of the problems. So this is my one of the concerns. The next thing is that like they talk about even in Ferdinand's presentation, he was talking about how the economic system, the health system, how they are deeply intertwined with each other. So that calls often in complexity approach, people, they propagate for interdisciplinary collaboration for understanding the wicked problems of the society so as to address the health or the social inequities. But I'm wondering if the scholars who are collaborating with this complexity lens, they speak the same language, whether they understand, because in social systems, the complexity theory emerged from the physical systems, such as the physics, biology, and this is directly imported now to the social systems, such as the health system or political economic system. These social systems are socially constructed, so perspectives vary, the stakeholders' perspectives vary, the meanings are socially constructed. If that is the case, then how we can arrive at a common language for the concepts or the themes that are there in the complexity theory? And if there is no common, another concern for me, the complexity theory so far. Ferdinand Chennai were actually illustrated how it can be used for the real world settings. But actually, so far, for whom it is these complexity theories serving the purpose? Let's have a quick look at that. So if you see the social movements, I would say that what academia could not achieve, social movements have achieved, I would say. That is the power of social movements. And they don't approach the activists who are involved in social movements. They don't apply any complexity theory to devise their strategies. Or if they had applied, then all the social movements would have merged together and they would have formed a broad coalition. But now what we see is that farmers fighting for their own cause, the health activists fighting for their own cause. So I see that for the practitioners, it's really the theory. Even for the policymakers, do they really understand the language of complexity theory? If you just tell them, the world is very complex, the problems you're facing is very complex, that's very vague and very abstract. It's not going to help, very helpful for them, especially in the emergency crisis like the one what we faced recently in the COVID-19 pandemic. It doesn't matter to them at all. And moreover, the policymakers, they can't pay attention to everything, to every issues. They can pay attention only to a small fraction of the issue to which they are responsible. It's overwhelming for the policymakers to make sense. And also, you also know the challenges associated with the translation of evidence with all the limitations, what I said earlier. So that I'm not sure if the evidence is completely translated to practice, and it is very easy to do that. So if that is the case, I don't know how far the policymakers have awareness about these complexities or the complexity theory approaches that you're talking about. So to me, what I have seen is that the complexity theory offers new insights, analytical methods, and conceptual frameworks. It has helped only the academia, the researchers, mainly to build their profile, to build their career. Even in that, I'm doubtful because of the fact that there's a huge politics around the way we generate knowledge and the challenges that is associated with access to knowledge. For example, the paywall mechanisms for the journals and all that. So even to the academia, it is not fully helping. So I'm not sure if it is really useful, this complexity sensitive approaches in the practical sense. So it's not only me doubting the usefulness of the complexity theory. So I just came across this blog written by who's an expert in using all these complexity sensitive approaches. So he has got an enlightenment during the COVID crisis. So he says that this is a very interesting blog you got to read. Right now, it feels like anything can derail everything. So our person who is critiquing the complexity, there are several other scholars who have realized the limitations of complexity approaches. And the other important, so we say that, things are complex. It's unpredictable, uncertain, there is positive feedback, negative feedback, all are interlinked in a non-linear fashion, all fashionable terms you use. So I'm wondering, in a way, you're actually inviting the policymakers to believe that they cannot control the policy processes and outcomes. At most, what they can do, maybe try to influence, do something about the complex adaptive systems. So don't you think it provides, in that way, the complexity theory provides a great excuse to take no blame for their actions? So they are not held responsible for their actions. So in the system, so when accountability is judged, you all know, it's like the dead end in our journey towards addressing the health inequities and social inequities. So the last question I have is for the complexity theories, do they really offer practical solutions? Even if that is what we listened so far, it's only the problems they highlighted. So they explain the problems in detail because that's very easy to do. That's what the complexity theories are doing it. So they even go to the mental power, the impact cost of the ones of police. So the hello, Paul?
Hello, Mina, yes?
Oh, yeah, I think I dropped off in between.
Okay. Yeah, so we lost your screen, the screen share, but you can continue probably. Okay, or you can come back.
And just last two, sorry for that technical problem.
No problem.
So I wonder, they focused more on the, more on the problems, not about the solutions. So even in the, for example, you see, Shenaz was talking about, it's a top-down now, the COVID-19 pandemic in the country, the value of life is put down. But I'm wondering, those Iceberg models, the intersectionality approach, does really offer the how of the solutions? Even the recommendations, you just say community should have been involved, but do you give any concrete, specific ways of engaging the communities? So my question for Shenaz is that how well should the government have engaged with the communities in the COVID management? Which communities should have been involved, given the diverse nature of the communities, and whose needs? Community needs vary from state to state, from even within the community, the needs of the people vary. So whose need matters? How do you arrive at that consensus? And in the case of Ferdinand's example, he was talking about the migrant issue of South Africa, which is a very complex issue. I agree that. But then you say in complexity sensitive approaches, you need to understand the systems are open, they are interacting in a very predictable manner and all that. So if that is the case, where do you start working on the solutions and where do you stop? How do you draw the boundaries for your work, for your vision or goal? And I'm wondering, is it fair if systems are so much connected nationally and internationally and subnationally? Is it fair to blame the South African government alone? And I also heard, things will change slowly, but steadily, but surely. All that I heard made it more useful in the long run, but not in emergency or crisis situations like the one what you're facing now. So in conclusion, I would like to say, I think I have adequately convinced you that the complexity sensitive approaches such as the Iceberg model or the intersectionality approaches, so on and so forth, are conceptually fantastic. They're very sound, very conceptually the more value about the complexity sensitive approaches. So I will just illustrate what I mean by that. You just think about this for the presenters who spoke before me. How would an Indian and South African policy team applying the ICE model or whatever complexity sensitive approaches look in the real world, and especially in emergency situations like COVID-19 pandemic? So I don't want to give a very distant picture, but I wanted to warn you all that you take this complexity sensitive approaches with all its limitations. So that's the point I want to make. I stop here. I'm very eager to listen to your responses and reactions on the questions posed. Thank you, Paul, and thank you, everyone. I stop.
Thank you. Thank you very much, Mina. I thank all the participants in this session who are following us. I recall that you can ask questions on the platform, on the virtual platform of the symposium. You can ask questions, and we are now going to have some interactions. And to guide that, I will just build on what Mina just asked as a really concrete questions about fundamentally, how do we move forward? The Iceberg model indeed have this second side, whereby it show how we use or tend to, the kind of policies we use to develop, depending on the level of the iceberg where we focus. So, for instance, when it's come to events, so we tend definitely to have what we can call reactive policies. So, do you see, first question to Ferdinand, do you see that there is a tendency when we focus only on events to have reactive policies? And when we want also to address inequity, to reduce really the gap between the various group of population in terms of having access or utilizing or having certain health outcomes. So what are your comments about this fact that when we focus on events only, we tend to have only reactive policies? Ferdinand?
Yes, thank you, Jean-Paul. Yes, first and foremost, I want to agree with you that at the level of events, most of the policies that you will get there are reactive policies. In the case that are presented around migrants and their inequalities, there are social groups, advocate groups like the Scalabrini and other migrant-sensitive groups in South Africa who are also raising up this issue and are speaking out on behalf of these people. And so sometimes the government hears this, sometimes it's also over the news. And so to address this situation, I think that the government will then adopt reactive policies. And most of these advocacy groups, they will they will start advocating based on events that they have seen, like the events that I have just shared with you. So these events might not sit well with them. They might be worrying to them, and so they would look for a way to address them, and sometimes they will go themselves to try to address it. I remember the Scalabrini Institute itself went to negotiate with banks that the banks should not block the bank accounts of foreign nationals because the Home Affairs is not open. And so Scalabrini went to the government and spoke to the government that they should also intervene and help them support a policy that will enable the banks not to block the bank accounts of foreign nationals, the bank accounts that have expired, of people who have expired documentation during this time. If they block these accounts, they will not be able to access their money. And the government actually did. And so it's just to agree with you that that was a reactive policy then, in a situation where Scalabrini opens the eyes of the government of what these people are facing and what could be done in that situation to alleviate their situation. Even though it was very short term, but then there was a reactive policy that was put into place, and the banks were informed that they should not block the accounts of foreign nationals, even if their permits are expired, because the Home Affairs is not open. So I agree that most of the policies will be reactive.
Thank you very much. But then when we go a bit down to look at anticipation, working with patterns and trends, what could the anticipatory policies in India, for instance, looks like? I want to address this question to Mina. Mina, if we wanted a little bit to develop more kind of anticipatory policies based on your knowledge of the context to address COVID-19 situation crisis in India, what anticipatory policies could look like in your context?
Thanks for the question, Paul. I mean, anticipatory policies, I think you really have to work a lot for that. I mean, it's not like it happens overnight. So there should be a kind of input for that. It is a long-term approach they need to adopt. The vision, there should be a vision for the government. With all the current challenges, the rising nationalism, I think that is hampering this kind of anticipatory policies. One definitive approach is definitely having a people-centered, realizing the true values of democracy. So some of these principles we need to revisit and, keep in mind while developing policies for the pertaining to the welfare of the people.
Thank you very much. I think what
it's
you
mainly
bring,
the people-centeredness that should come, and the value of life.
So you are coming. So I want to take 2 points to take two main points from your response. So the long-term approach. So we need more long-term way of develop a more long-term vision, and also you mentioned that we have to act on the way democracy work and how the value of life is considered. I want to ask the same question to the external, the one who is external to India, here, Shinaz. So when it's come, for instance, to develop anticipatory policies, what can those policies look like in India when it's come to the reaction against COVID-19? What kind of anticipatory policies could have been in place to reduce what we have seen as reactive policies in India?
Thank you so much, Jean-Paul. I mean, I think that when it comes to a pandemic, the WHO had actually formed a new kind of pandemic response unit. I think the Ebola crisis, the Zika virus, MERS, the other coronavirus that came about, really gave the world a sense that we are in a kind of environmental space in the world where we can start to predict or anticipate that there may be a pandemic that will come, and how do we respond? I think that in that kind of situation, Mina mentioned a people-centered response. And I think that this is really grounded in the fact that you have to shift your value system of your health system at the very start, regardless of whether there's a pandemic or not. It has to, you need to, one of your anticipatory things should be a strong, resilient health system that can withstand, survive, cope with any shocks that come to it in the first place. And in order to do that, the health system needs to be one that does really take seriously health for all, and that does try to be a health system that is not a band-aid for the other systems like the economic system and the military system, the political climate. Instead, that the health system is built upon the values of equity, social justice, and takes a stronger role in bridging income inequality, wealth inequalities, and other inequalities, such that there is a similar standard of health that people can access regardless of your circumstance of birth and wealth and so forth, or ability. So I think for me, to anticipate and to respond to a crisis, you cannot have a broken health system. You actually need a functioning health system, and you need a government that is committed to producing that, not for some, but for all. And yeah, and I think that if you, the other thing is that it also goes back to how we understand systems, right? So systems operate regardless of whether we want to name it a system or not name it a system. So like the environmental system, because humans have had to make sense of, find vocabulary to describe it, and even the health system. Every different researcher or person decides what they would like to constitute the health system or not. But it's a system that operates regardless. So for us to really make sense of these systems, it does build upon what is your intention for the system and what is your intention in the face of other systems. And we found with COVID-19, I'm just going to end with this, in South Africa, where I come from, during the December period, one of our COVID response was to stop the sale of alcohol. And we found that in New Year's Eve, the unit in Johannesburg, in Background Hospital, that is overcrowded and burdened and at its highest peak, in New Year's Eve, the trauma unit actually had empty beds. So it makes us think in South Africa, what have we been tolerating? What have we been putting up with? And whose lives really matters? Yeah.
Thank you very much for that. Then when we go deeper and think about the design policies or the redesigning policies, so we still have just a few minutes, so I will turn this question to Guillermo. Guillermo, what can it look like to develop what we can call structures redesign policies to address inequity in health? What are your comments or your reflections about that? Guillermo? So eventually I can turn this. Guillermo, are you there? Probably having some, can you unmute yourself?
Jean-Paul, I just wanted to know, are we supposed to respond to Mina's questions? Because she asked us some questions. Is there time for that, or are you just leaving that as questions to think about?
I think if you have a quick response to that, you can go quickly ahead, and we can continue. Just like 1 minute briefly.
I don't have a 1 minute response, but I will say this much. I mean, she actually answered her own question around how to engage communities. It is a people-centered approach, and that that's quite clear, and it's been a recommendation since we've had the Alma Ata recommendation years ago. So I think governments have really failed in developing comprehensive primary health care, and really taking people-centered ideas to design methods that will come up. And the second thing I'd like to say is just to push back at Mina to say that if we assume that policymakers can't deal with complexity, then are we saying our policymakers are like not fit for office? I think it's not good enough for me to say that policymakers cannot deal with complexity. And I think researchers have to, first of all, declare who they are and their positionality in who and in when they come to the table, because every researcher comes with their own value system and their own issue, their own agenda. So researcher is completely lacking in bias. So even a researcher comes and provides a biased analysis with a biased result, but then the policymaker needs to be able to handle complexity, and they need to be able to translate complex ideas into small, manageable solutions that deal with the complexity. And often you find in complex systems approach, if you a lot of the problems boil down to one or two wicked issues, like stimulating the economy for all people and not for the rich. And I think that has a ripple effect. So I don't think policymakers, it's good enough for them to not complexity. I think about willingness. Thank you.
Thank you very much, Shinaz, because in the same way you address also some element about redesign structures. For instance, you really mentioned the way policymakers, who should be a good policymaker. Should policymakers be selected in the way to have tools and capacities and trainings to understand and to work with complexity? If Ferdinand is in the room, I will give him the floor for 2 minutes to tell us a bit what could transformative policies could look like to address the issue of migrants in South Africa. So when we really go deep down to look for transformative policies that can address mental models, the way people think and believe, what kind of policies you think can be effective at this stage, at this level of analysis and action? Yes, so we have very few minutes, like in 2 minutes. What can you tell about that?
Yes, I'll give you a response in 2 minutes. Thank you, Jean-Paul. Transformative policies indeed are the kind of policies that are required for the South African system and to address the problems that these migrants face. Number one, at the level of transformative policies, you need to recognize that inequity remains a big problem. And so the focus here should not be to address the inequities vis-a-vis foreign nationals only, but try to remove inequity in general within the political system, the health system in the country. Once you are focused on equity, all the other policies that will be developed will just flow down from your mindset of equity. And so irrespective of the population that you are looking at, the first thing that will come to your mind, how do we provide equity to this group of people? And so the problem that we are facing is that there is still the mindset of inequity, like I said in my presentation, which is the relics of the apartheid system. And when we address the issue of inequity, then we can address all the issues in South Africa, including that of the migrants. Thank you.
Wendy.
Thank you very much to all of you. We are now a little bit over time. Thank you for your participation in this session. It has been very, we have been very happy to have you there. thank you for joining us for this session, and goodbye. Thank you. Bye. Thank you to all the presenters, and thanks to all the participants. Bye.
Bye. Thank you very much.
Thank you all.
Thank you very much, Guillermo. Thank you.
Thank you very much. Thank you for the opportunity.
Thank you.
Thank you, everybody.